can kind of just kick us off, and then maybe we'll alternate questions. Sound good? Okay, great.
Works for me.
Oh, well, welcome everyone. Welcome. We're really excited to be here with you. We were just getting a little behind the scenes stuff sorted, but I'm honored to be here. I'm Chelsea. I'm the founder and director of Eat, Breathe, Thrive, and we are so excited to be hosting this panel discussion in partnership with ANAD. And I'm so excited to be here with this incredible group of panelists to talk about a topic that, we were saying even before we just got started today that it's a hugely consequential topic in all healthcare, really, in eating disorder care, especially autonomy. And it's something that since our research study was released last week, which uncovered about at least 60 cases of patients with eating disorders that have been assisted in suicide or euthanized in a number of countries throughout the world. It's a topic that comes up over and over again. This question of, well, shouldn't we be respecting patients' autonomy? Isn't this decision a decision this person has the right to make? And of course, in eating disorder care and treatment, there is so many examples of individuals with eating disorders being deprived of autonomy, of iatrogenic harm, of people not being able to be at the center and directing their own healthcare. So it is a rich discussion, and it's one that we've wanted to have as organizations, as clinicians, as people with lived experience of these issues. And we wanted to open it up in dialogue, in a safe and respectful dialogue. And we also want to welcome you into this conversation.
Can I say, someone put in the chat that they need captions for accessibility. Can we please do that?
Thank you for that reminder. I know Mel was working on that. Mel, can we make sure we've got captions turned on?
Captions are turned on. Just go to your bar at the bottom and click the captions, and you'll be able to turn them on your device.
Thank you.
Excellent. Thank you. So on that note, that's just sort of setting the stage for our discussion. I want to hand it to Jason at ANAD. Jason, do you want to maybe just quickly introduce our panelists and ask our first question?
Yeah, absolutely. So thank you so much, Chelsea. I'm very excited to have this conversation today. And I really appreciate you having this conversation, because I guess to give a little bit more background on how this even came about was, as the joint statement was being prepared, I wanted to make sure that we were really being mindful of autonomy. And I know that this is such a nuanced topic, and that there's many different perspectives, and it can be an emotionally charged topic to talk about. And it's a conversation that a lot of us maybe don't want to have, but now we are having it. So I'm just really glad that we're able to come together, our two organizations today, and have this conversation. So yeah, I will go ahead and start introducing the panelists. But first, I've got to introduce Joss, who joined us for This Is My Brave. Anna presents This Is My Brave earlier this year, and is now a member of our Community Engagement Committee. And Joss, I am so grateful for all of your perspective and experience that you bring. Would you like to go ahead and introduce yourself quickly?
Sure. Hi, I'm Joss. Yeah, I am on the Community Engagement Board, and I'm also an MFA student and a person with lived experience. I'm very happy to be here.
Awesome. All right, great. And next up is a gentleman that I've had the opportunity to connect with several times through virtual. I don't know if we've ever been on the same event before. This is pretty cool that we get to do this, James. But James, would you like to go ahead and introduce yourself?
Yeah, sure. I'm James. I'm here in the UK, and I'm an expert by experience of eating disorders, anorexia and bulimia the last 20 years. And I do various pieces of research and policy work, as well as supporting people individually. I'm also a yoga teacher as well. I just got to say right at the start that I had quite intense dental surgery yesterday. So I'm a little bit swollen, and that is one consequence of eating disorder impacts But I'm noticing that I'm doing quite well with actually speaking because I've got this funny sort of retainer thing in. But if I struggle, I will let you know. Um, but yeah, it's nice to see you and see to connect with people who I think I've known various people in this space for a while, but not actually connected.
Yeah, awesome. Well, you sound great on our end. So yeah, hope that you're feeling better soon. And then lastly on the panel today is Dr. Maria Rago, who is the president of the board at ANID. And I've had the opportunity to get to know in the last year and a half since I joined ANID. Maria, would you like to go ahead and introduce yourself?
Sure. Thank you so much, Jason. Yeah, I'm honored to be president of ANAD, and I think it's really important to advocate for people with eating disorders regarding autonomy. There's really complicated issues, and I'm happy to, I feel like professionals need to support people with eating disorders in the best ways that we can. So I'm deferring to you guys, but glad to give some perspective as well.
Awesome. Thanks so much. And I realized I was introducing everybody else and didn't introduce myself, but I am the Director of Community Engagement at ANID. I came to terms with my eating disorder, was diagnosed back in 2020, and over the last couple of years have just really turned it into a mission to share my lived experience and hopefully help other people find and get the help that they need. So again, Chelsea, thank you so much for bringing us together for this discussion today. Would you like to go ahead and kick us off with the first question?
Sure. Thanks, Jason. Yes, our first question is really just kind of to set the stage in defining terms. I want to ask anyone, and not everyone has to share. If you feel called to share, you can. We can kind of keep this fairly informal. But I think one of the challenges is that we're using the term autonomy in lots of different ways. So sometimes when I say autonomy and you say autonomy, we may have very different meanings for what we mean by autonomy. There's different definitions of autonomy, in research versus clinical practice. So that's my first question: is where are you starting with? How do you understand the meaning of autonomy and what it means to support autonomy in healthcare? And how, if at all, do your personal or professional experiences inform your understanding? All right, James, see a hand up.
Yeah, I might as well go first. I think that this is a huge subject, isn't it? And we could do several discussions just on this and thinking about how we conceptualize autonomy. I think like I don't have a singular definition myself, even as one person. And I'm trying to think, could I give a range of options of what we could think as autonomy? But I'm just going to think about my own experience actually and think that for me, it's something about self-efficacy and being able to have some sense of being able to enact change in my own life. And I think that when I haven't felt autonomy, I've has been some of the times when I felt most unwell. And so I'm thinking of it sort of by contrast. So when I feel like things are just happening to me and I don't really have a say in that, and I don't have a choice about what I'm going to do, whether that's, something in my work life or something in my healthcare, in itself, like that for me is a state of not feeling well. That tends to be when I feel my worst. And in itself, that actually can be quite traumatizing at worst, but certainly create a sense of sort of dis-ease. And so I think that if it's sort of thinking about it in that way, it's a state of not feeling well or being unwell can make us have less autonomy. And I suppose on the flip side of it, that there's something about health and being well that means that we have some self-efficacy and some autonomy. And so when I'm thinking about eating disorders, certainly for me, having a severe eating disorder has meant that I've not had as much agency, autonomy, self-efficacy, whatever word I want to use for it, because it's been so limiting on my ability to do things, my ability to live my life. And so being better with my eating disorder and recovering from my eating disorder will naturally give me more self-autonomy and more choices and more options of what to do with my health. So I think that framing it in that way and that actually recovery and treatment enables more autonomy on a general level, and hopefully the treatment itself has autonomy and is done collaboratively. I think that we can't forget that actually health, better health will lead to more autonomy, and it's like discussions that we sometimes have about quality of life, I'm kind of like, well, recovery leads to quality of life. Quality of life improves when we recover. So any treatment should be addressing that, not just some treatments, which I think happens. So this idea of sort of feeling like things are being done to me is the opposite, I guess, of autonomy. I know what that feels like. I don't have the best language for it, and I'm struggling a bit to get the words out because of my teeth. But I think that having something done to you isn't ideal in treatment. But then we end up going so far the other way, I think, at least in my own experience, that because we don't want to do things to people that they don't like, and then we end up with this sort of hyper responsibilization is one of my favorite words of people, that my experience has been that I've had so much autonomy in the sense that nobody's helped me when I've really needed it. And so actually I'm kind of approaching this subject a bit like, well, I don't want as much autonomy. I don't want to have to do the work of asking all the time. I want help to be offered to me rather than for me to have to sort of get so unwell and beg for it. And we're so individualistic about things. We're so sort of focused on patients being independent and having to take responsibility and all this kind of stuff. And I'm kind of like, you know, treatment doesn't have to be stuff being done to you, but sometimes you do need things doing, and things that you need to do to get better are very painful and not going to be nice, and you need the appropriate support for it. But, you know, that doesn't mean that we leave people high and dry and have to do absolutely everything for themselves. There's this sense somewhere in the middle of alongsideness and being with that is actually very agency supporting, autonomy supporting, I think. But it's not, it doesn't look like one or the other, the sort of complete freedom and whatever the patient thinks they're right. And it's not complete dependence. And I think we have such a fear of making patients dependent on care that I think actually good treatment means you work with somebody, alongside somebody, and you can learn to be dependent then, which I think many people with eating disorders actually like haven't been able to be dependent on anybody for reliable healthcare. But there's something about that sort of shared relational work that actually supports somebody to step into their own health and their agency and their defense. Because I think when you get better, you don't want to depend on somebody anymore for treatment that you don't need. So that's the way that I'm thinking about it. But it's huge and it's confusing even to start to think about. So hopefully we can keep delving into it.
James, I love that you bring up that dialectic between autonomy and individual choices, and then also the need for care and protection. It's really important. I wonder if Joss or Dr. Rego, if you might comment. I might also just add another question, because there's an experience of autonomy, and there's also what it means to make an autonomous decision. So, you know, when we're saying supporting autonomy, what it means to make a healthcare decision that is reflective of autonomy. I'm curious if you might have insight on that.
Well, I think, you know, if I think about autonomy for individuals, it's wanting the person to find their voice, wanting them to find their power. And, you know, one of the complications sometimes is if you have an eating disorder, your motivation might be mixed about your recovery. So then that becomes a challenge to, you know, so, and when people will say, well, this patient is resistant, like, yeah, they have an eating disorder. It's like part of the way eating disorders work. There's nothing to get, you know, nothing to get surprised about. It's okay. I feel like accepting the human being, the humanness, the mixed feelings. I think one of the worst things that can happen is like power struggling with individuals when you're working in treatment is like, no, we're going to do it my way. Except the only exception of that is if someone's using like really poor judgment. And so the judgment piece comes in that becomes, you know, if somebody says, well, I'm really depressed, I have a right to kill myself. So then that gets like, we want to stop, we want to help people, because even though people might have a right to want that, what if depression's causing them to want that? And then if they weren't depressed, they would feel differently. So we don't, you know, it's not, we don't want people making decisions when they're extremely depressed. Or what if one of the big reasons about people giving up is their lack of access to treatment? Because James, you have brought up, you know, like people will say, well, I don't want to live like this. well, let's live a different way and provide solutions and support.
Yeah, beautiful. Thank you, Dr. Vega. I just heard in that, there's that, especially as a healthcare provider, you have a duty to prevent harm as well as respect autonomy. So there's not just one ethical duty that we have in healthcare. We've got respecting autonomy, non-maleficence, which is preventing harm, beneficence, which is doing good. And we also have a duty to justice, which is what you spoke to in terms of access to care, making sure all people have access to the support they need. Yeah, Joss? Or I can go to the next question. We can go to the next question. Or Jason, you want to weigh in.
Yeah, one of the things that I was just going to add is immediately when I think of autonomy and I think about my own personal experience with it, is it's being heard and being involved and feeling empowered. And to me, that was very important throughout my recovery journey, is that I always felt empowered with my providers and that I could still talk to them, even though at times, I was thinking irrationally or things weren't always making sense to me. At least I could have those conversations. And I think that it requires, kind of bouncing off of what Maria was talking about, is that humanness and that humanistic approach. And realizing that a lot of times when it comes to eating disorder treatment and recovery, it's not a textbook case. It's not a black or white case. Every situation is going to be unique. It's going to be different. And that's why it's so important to have those conversations and to really get to understand the patients and the individuals that you're working with, because through doing that, you can empower them at some level, in some regard. And to me, that's immediately, like, when somebody asks me about autonomy, that's kind of what pops into my head right away.
Sorry, I'm checking with Joss. Can you unmute now? Are you good to? We've had you for a second. Okay, I'm going to ask for tech support here. But Jason, I love what you said about just the lived experience of autonomy, that it's feeling empowered, feeling like you actually are actively able to make decisions in your healthcare, and that your voice is respected and honored. And I think that's you get away from the clinical definitions. That's exactly what that means from how we feel. Our tech team, we're having a trouble unmuting one of our panelists, Josh. So I'm gonna see if I
Josh,
can
you
get
should
some.
be able to unmute yourself now.
Oh, yeah. That did work. Sorry about that. Let's see. Yeah, I think as a person with lived experience of being kind of labeled this revolving door patient, and that aspect of needing treatment multiple times to kind of get to the point where I was seeing in a different way or logically, I do think that autonomy for me has meant making decisions in conjunction with a treatment team that has my best interests at heart, but also recognizing that there are things that come up that make suffering hard to come out of. Like co-occurring disorders, like chronic illnesses that can come from eating disorders, complex trauma that undermines eating disorders. So I think it's an incredibly difficult thing to talk about without talking about the suffering that comes from long-term eating disorders. I don't necessarily believe in the concept of a terminal eating disorder, but I do believe that the things that are left in the wake of eating disorders can be terminal.
Yeah.
I would just agree a lot with what you just said, and it made me think about treatment experiences of going in and out of hospital and needing sort of life-saving treatment when I haven't wanted it, and the sort of brute fact that if I was going to stay alive, I would need to have these things done that I didn't like and that weren't pleasant, and that could be, and I resisted that and was ambivalent about it because I didn't really trust that it would be a bearable experience because of past harms that I'd had. But I don't think the solution that I think sort of misinterpretation of autonomy then would be to say, oh, well, the patient isn't motivated to have that treatment. They don't want it. They're able to make this decision. They've got capacity and this kind of stuff. And that has happened to me where I've been able to discharge myself from those situations because I've been able to explain how electrolytes work in the body or something very articulately, but at sort of immediate risk of cardiac arrest, you know? And I sort of don't want to be allowed to leave in those situations, but it's the how difficult I find going through the treatment that has made me want to. So it's when I've been in a better state of mind, I have been able to say, I don't want to be allowed to leave, and I have been allowed to leave. At other times, it's felt very sort of that, like I've said about something's being done to me or coercive or you know, is sort of traumatic, but it has saved my life, and I am retrospectively grateful for that, even though I think that it could have been done better. There is a space in between, I think, where you have to go through something that is horrible, and I think that recovery is very difficult anyway, for most people, and often involves some very, very horrible experiences that are emotionally painful, physically painful, suffering. But there are ways I think that it can be you can be supported through it and that alongsideness and that sort of being withness that I think you that came out to me from what you were saying, Joss, that I think that for me is dignified care and that is a sort of enough autonomy for me. But I think sort of being able to understand what's happening, you know, basic principles of care like collaborative decisions or people telling you information about what's going to happen and guiding you through it and having trusting relationships, that kind of stuff. And it just makes me think of this thing with the teeth, like as an example, that I had to have lots of teeth out yesterday and I really didn't want to do it. And it was really painful. And not, you know, like I said, recovery involves going through things that are not going to be nice. And if I didn't have those conversations with the care provider of like, this is what's going to happen here and then next and then this, and we're going to give you sort of, you know, pain relief here, but it's still going to be really uncomfortable. It's not going to be that you can have this sort of perfect experience and not have to put in any effort. You know, because I could have those conversations and that information, yeah, I didn't like I could make that decision. And I kind of actually didn't really have much choice in making that decision because I had infection there. And if I'd have left it, you know, it might have been an emergency situation, but I felt like I had dignity and autonomy in that. And I just think the parallel with eating disorders is a little bit sometimes like, you know, you're not given the pain relief and you're not given adequate psychological support alongside, say, behavior change, you know, with that sort of holistic package of care. And we see it maybe a lot better in other areas of medicine or in that example that I gave about my teeth. But I don't think that it's, um, you know, realistic to think that if somebody's going to find something difficult and they say no, like, well, I think, of course, that is realistic, that people don't want to do things that are difficult. That should be expected, but then the appropriate support has to go alongside it. And I think that's really where we fall down at the moment, is that we don't have enough support alongside it. And then we end up saying, oh, it's the patient's fault, or they're not motivated enough to do their own anesthetic and pull their own teeth out. You know, like that metaphor's a bit clumsy, but I think that it can be done, that this care that can be really difficult doesn't have to be coercive. It can be collaborative.
Yeah. I just want to throw in one kind of more thing, and then we can go to the next question, maybe from Jason. But I, I, I come at this from both a lived experience standpoint, and then also, you know, as somebody that's worked with people with eating disorders over the last few years. And just what you were sharing, but I didn't intend to go there, but it brings up so much of you know, eating disorders. They come with a huge there's so much suffering in this illness, in psychological suffering, physical suffering. It's one of the few mental illnesses that comes with, you know, as James has just spoken to, a number of physical complications that sometimes are not actually, you know, are not going to reverse. These are things you live with the rest of your life. And if you both don't have access to care and you're sitting with the reality of that, you know, you're in a very low place psychologically, you're dealing with maybe medical issues that will not reverse. The grief and the mourning that comes with that, and the vulnerability and sometimes the hopelessness is huge, you know, and sometimes it can feel bigger than anything, and like it's never going to go away, and you might as well just not be here anymore. I have known those moments. I have been in those moments. And I think whatever is out there, that when I was in those moments and I said I would rather die than go forward, just let me go. I'm so grateful that my physicians didn't listen to me. I'm so grateful. I have a beautiful, wonderful life now. And in the moment, I would have told you with so much certainty that that was what I wanted. And I find it really befuddling that, you know, I've worked on inpatient units, and I've residential care. And one of the first things we do when someone comes in as a team, if they have been suicidal or they're feeling suicidal, one of the first things we do is take away their shoelaces and their sharps. That's one of the first things we do. We don't say, well, a patient has autonomy and they have a right to injure their body if they wish to. That's not a controversial thing. So I'm so confused that when it comes to lethal medications, we feel differently about that. And I'm not saying, you know, that people don't have a right to end their own life. I'm saying as healthcare providers, as mental health care providers in particular, knowing the great suffering that comes with this illness, knowing that the symptoms of this illness are often a wish to die. Why are we treating this differently? Why are we saying autonomy looks different now? That's what I don't understand. Yeah.
And I think, like what you're saying, it's important to connect with that soul inside that individual. There's a way of hearing and listening that doesn't, if someone says, well, I want to kill myself, that you don't say, oh, okay, I hear what you're saying, let's go. You know, you want to hear, okay, I hear that you're in pain, that this is too hard for you, that this is suffering, and there could be other ways to alleviate it, and let's try something different. Or so, because I think, you know, it's kind of crazy that providers, in a way, they are hearing and they are responding, but like they're responding to the wrong thing. You know, be like, if I have an eating disorder and I'm in the hospital, I want to order like a double stuffed pizza at midnight. No, you can't. You know, it doesn't mean, you know, okay, I hear you're hungry. I hear that that's you know, something that you want. Maybe we can have a piece for lunch tomorrow or something, but you don't go get that pizza. We don't have to go get medicines and kill everyone, you know. So I think, anyway, I'm saying it's a type of listening where you hear the heart of the human and you hear the suffering, but you don't have to do actions to you know, to intervene. In fact, the right action might be saying, okay, why don't you stay at the hospital now, because if you're feeling that way, we'll help you get through this time, and then, you know, hopefully you won't be feeling that way with a little more time and some different treatment.
Okay, yeah, thanks for sharing that, Maria. Sorry, I'm getting choked up over here. I think a lot of it comes down to the need for compassionate care. And unfortunately, I think that's still lacking a lot when it comes to whether it's eating disorder treatment or just healthcare in general. Oftentimes that level of compassion and that humanistic approach is missing, is void. And it can cause, I think, these really sharp lines, these really sharp boundaries, then when it comes to trying to balance individual autonomy and preventing harm, which kind of leads into what our next question was going to be. And we've already talked about it some, but how do we balance individual autonomy with also that duty to prevent harm when it comes to the context of eating disorders?
I would love to start by saying I think that having conversations around the availability of harm reduction and harm reduction as a valid recovery tactic is something that really needs to be talked about more. Also, especially within the context of chronic illness, I can speak to someone who has gastroparesis. The way that treatment has looked for me has looked very differently than it has for other people who have gone through treatment. I can't follow a specific meal plan in the same way that another person might, because of physical symptoms that come up for me. And talking about how we mitigate harm, whether that means that we don't achieve full recovery, I think that's a conversation that we need to be able to have within eating disorder care. Um, and defining what recovery looks like for people, because that's very broad and different for everyone, depending on what you have going on medically or psychiatrically.
I also struggle with gastroparesis, and it means that the pretty narrow, but the way that I think personally think pretty narrow way that we think about recovery and what that looks like and how that might look on a dietary level for people who have co-occurring conditions, which are many people with eating disorders. I think that that doesn't really help and actually can be in itself harmful for people who don't fit and are able to do that. So I would echo that a lot. I think I really loved what you said about harm reduction as a recovery tool, because for me, I do worry about sort of maybe a misuse of harm reduction in that it can just be used as a way to sort of justify managed decline. And I personally think that a lot of my care has just been a managed decline when I've experienced it recently. And yes, it might be that some of the harms of getting more and more unwell have been slowed down a little bit, or my decline has been very well medically monitored. That isn't the same as treatment. And I think that it can be thought about in a different way where harm reduction is always sort of ultimately oriented towards recovery, however that looks for somebody with different conditions. And I think that that's a subtle difference, but it's a really, really important difference to me. And I think that many people, for lots of different reasons, might not be able to go with sort of conventional treatment, I guess, that's not adapted. And I think a lot of treatments are a lot more flexible than they're actually implemented. But many people might not fit into the treatment that's available to them. And therefore they have nothing, or they just have this sort of managed decline. And actually, there's some space there in between where the door is always open towards that more sort of behavior change and that kind of stuff. And it prepares people and gets them ready in terms of what will it look like for them to do recovery, but not in a way that's sort of like, oh, let's sit around and contemplate whether you want to get better, because who wants to go through these really difficult things? And I think that we focus too much on motivation. And I know that we've talked a bit about these sort of impacts, physical impacts and things, and I'm not sure actually. I'm kind of disagreeing a little bit, Chelsea. I'm not sure how many of the impacts are actually long term and irreversible in eating disorders. I think there's the teeth example, there's maybe bone density and things like this over time, but so much more than we think is actually reversible, and the body is miraculous in its ability to recover and to find a new balance and a new sort of status quo. And I think that um, a lot of harm, I suppose, talking about harm, comes from these narratives that we have about eating disorders, that they are inherently somehow progressive. Where's the evidence for that? They can be interrupted and changed, even spontaneously, people recover for reasons that are not documented, and they're really, remote from services. And actually, I think that some of these narratives that say people are always going to be unwell, or you're going to live with this for the rest of your life, stuff that I was told, they can sometimes actually be sort of introjected into people and become self-fulfilling prophecies. And I think that this is a huge problem that we have in terms of harm. So harm reduction, I think, has to involve actually looking at what kinds of harms there are, and they're not just forcing people to do things that they don't want to do. They're not just iatrogenic harm in that sense. It's also actually how we think about and conceptualize eating disorders and the possibilities of recovery as well. So I think that we have to really examine that language and not curtail people's opportunities, what they can believe in before they've even started. Because I think a lot of the reasons why I haven't wanted to do things that are difficult to get better, and that whole autonomy question comes in, it's because I haven't believed that they were possible, and so I think that's a huge one.
Yeah, I'm so glad you named that, James. I couldn't agree more. The narratives that are so pessimistic, and I was told so many times this is something that will always be that little dark thing on your shoulder that will always be there. And that is in some ways subtly coercive. It's obviously not intentionally coercive, but thinking about coercive at a systemic level, if knowing that those narratives are out there floating around, sometimes our peer groups, sometimes from our clinicians and healthcare providers, if that is the story you're taking into that decision, well, this is something I'm going to live with the rest of my life and it's never going to get better. I don't know how you can make a capable choice. Think one thing I'd add also to this discussion, I think the question around like how do we balance an individual like respecting autonomy and our duty to prevent harm. One thing that was really helpful to me in the writing of this paper is I was sort of forced to do a deep dive into all of the laws on assisted dying and all these decisions. And something that comes up a lot is mental capacity and whether a person has the mental capacity to make a decision. There's one of our signatories, Dr. Ann Henson, said this to me the other day, and I was like, wow, it's so well put. I hope I don't butcher it. But she just said, the threshold for mental capacity in these decisions, the legal threshold is so low, you would have to be comatose not to meet it. And that's coming from a forensic psychiatrist with specialization in this. And she also said, really, you need to understand two things to get to be considered capable. One is that you have a terminal condition, and the second is that if you drink this lethal cocktail, you will die, which is not a very high bar. But something that was very helpful to me in that mental capacity understanding is that in healthcare, we can understand that a person might have the ability to make some types of healthcare decisions and not others. So we can recognize that a person has the right to refuse treatment, like a particular type of treatment. When I was hospitalized, I was involuntarily given drugs that I didn't want to take, right? So we can respect a patient's autonomy by saying you do have the right actually to refuse that, while also recognizing that they may not have the right or the capacity at that moment in the depths of a mental illness, not a right so much, but the capacity to make a decision that ends their life and actually ends their ability to exercise their autonomy in the future, because there is no life with which to do that. The other thing I just add, I love, Joss, that you brought up harm reduction, and James, you spoke to this. I love harm reduction. I don't love the term harm reduction because I'm like, we can do better than harm reduction. So I think of this really also about, just add that it's also about not just reducing harm, but supporting quality of life. One of the reasons that often people feel really hopeless is because their life is full of suffering. So part of harm reduction as an approach, and I know someone asked about this, is actually I'm not saying improve quality of life at the expense of recovery-focused treatments. I want to be really clear. I don't think that that's a dichotomy, but recognizing that to recover from an eating disorder, we have to have a reason to recover. We have to have a life worth living for. We have to have a reason to get up in the day. And so much of our treatment is just focused on symptom reduction, ceasing behaviors, all that kind of stuff. I'm like, how do you connect this person back into their community and back into the life that makes them want to get up in the morning, that makes them want to nourish their body, that makes them want to have a good life? And so to me, it's harm reduction plus. And this so much bigger than just reducing harm. It's connecting a person back to life.
And you can look at it like, if you look across a long period of time, that's really helpful, because maybe today in this moment you don't agree to go to the hospital, or maybe today in this moment you don't agree to gain 2 pounds, but that doesn't mean you should never get treatment. So you can see what you're willing, like with your own autonomy, what can you manage right now and what can you handle and what's the most you could do. But because sometimes this idea of treatment resistance or treatment failures, they can follow a person. Now you're diagnosed with treatment failures. Well, maybe I wasn't ready for the treatment on August 5th, but maybe, October 1st, I'll be ready for the treatment. So that's one thing that, like, and especially when you look at longitudinal studies of recovery, maybe 6 years out, 20% of people are recovered, but 20 years out, 70% of people are recovered. So it's definitely a marathon, not a sprint when it comes to recovery. And that's why the interventions we do have to be flexible, not only at the moment you enter the treatment, but knowing that just whatever, let's do what you can today, right now, knowing that we can modify the goals, we can make you, as your autonomy, as your mind changes, as what you want changes, but also supporting the health of the person. And what is, I think quality of life, years ago, research started looking at recovery as quality of life. Like, what is recovery? Well, maybe I'm not to the point where I have no behaviors or no thoughts, but I have improved my health. I've improved, the how nice it is to be alive today. And I kind of look at harm reduction like that, but I love, James, I've never heard anybody talk about it as a way to passively manage decline in a person. And it's horrifying, but true that sometimes harm reduction is just a lazy way to say, well, the person doesn't want to do it right now, so we'll just do nothing. Make sure we'll check their medical health. It's that it lacks aggression. So of course, as providers, we want to be aggressive, but we don't want to overpower people and take away I don't know, like I want to take away your rights, but I don't. Like I want to take away certain things that I think you would regret, or at least give you an opportunity to try it now, knowing that you can always do something later.
Yeah, everything that you said, I agree. And Chelsea, everything that you've said, I've just been like, that is so on on the point. And I think that if autonomy is sort of self-efficacy and being able to affect change in your life, if you only have a negative motivation, like you said, like the idea of um like rather than thinking about what kind of life do you want to have, what kind of a change do you want to affect in your life, instead it's just you don't want to be ill, you don't want this bad thing to happen. Like if you don't have that positive motivation, then why would you want or need to have autonomy if you don't believe that there is a life there worth having and changes that you actually can make? So this is where I think that this hope and faith is just so important, and the narratives are so important. And futility comes in when you think, what is the point if something isn't going to work? This sort of sense of prediction being built in. And this is why I have a problem with this idea of enduringness, because it sort of builds in that predictability that things are always going to be bad or always getting worse. And like there is a completely different story to tell for so many people, for actually the vast majority of people who longitudinally recover. Like what an amazing message that we never hear. When I read those statistics and there's recent meta-analysis and everything, I thought, wow, that just blows my mind, because I was told something completely different, and I'm not even sure if many clinicians are aware of that data. And we don't hear that, and that story isn't false hope and telling people, oh, everything will be all right next week if you just sort of think positive and you can get better and off you go. Like it's actually perhaps going to help people to get through the really difficult bits because they see there's a point and that actually they can do it and they believe that they can do it. And life can be radically different. My life, I'm not fully recovered, but it's completely different from when I had severe anorexia. And like when I had a recent sort of relapse with struggling with electrolytes and things, it really hit home to me how even at a normal weight, like nutrition can completely change your perspective on the world. Like with a low potassium, the world looks completely different to me. It looks so bleak. There's no point doing anything. I'm suicidal. And like just that one metric, that when that is replenished, it's like the heavens lifting, and like I see things differently. Different options are possible. And I think that we just lose sight that for people who we think are so stuck, and people who really feel stuck and they seem like we've tried everything, and maybe we have, and maybe we just haven't tried with enough resources or haven't tried in certain ways, and the quality, hasn't been attended to. But for these people, actually, even then, there are other options and there are other ways of being in the world that are possible with the right conditions, the right support, and I think that we just completely lose sight of that. I never hear that or see that. And like you said, that thing of a life worth living, I was never asked, what do you want your life to be like? People just assumed that I would be able to go off and have whatever life I wanted to have because I was clever or something. But I was ill. Like, and the motivation of, well, you don't want to get more ill, do you? That wasn't enough motivation for me. But at the same time, I was boxed into, but you can't actually get better. Like it just really confines people. And I think that absolutely has to change.
Thanks, James. Yeah, I just want to mention, the study we just did, 67% of the patients that we reviewed that had descriptive cases were malnourished and severely underweight. And it was so striking to me because having, like you, been at a very, severely malnourished place, there is no way I could have made clear decisions. No way. And I bet I looked lucid as all out curse word. Like I could talk my way around doctors in circles, so I think that's so important. And I think it's important to listen to the voices of people that have had experiences of those, low potassium, altered electrolytes, being in a altered body, even like losing a lot of weight in a short period of time, whether you're a low BMI or not, can alter thinking. And I think it's something that maybe from the outside is hard for someone to understand, but I think it's really important those voices be listened to. I want to just, we said it in the chat, but please do feel free. Oh, there's a question. I was going to say, if you'd like to ask a question, you're all here and we want to talk with you and hear from you. So Jason, if you
One of the things I wanted to just kind of interject into the conversation, because I know that we're talking about the majority of cases where the effects can be reversed, but there is a small number of individuals where it is a serious, irreversible damage has been done to their physical body. And it's one of the first questions that we had in the chat a little bit early on in the conversation, but it's around the conversation of what if somebody has a complication that just makes full recovery impossible, such as complete intestinal failure? And in that regard, how do you consider the resistance to medical aid in dying for mental health reasons towards an actual valid medical reason instead? So I think that's an important part that we still examine. While it might be a smaller number of individuals out there, it's definitely part of this conversation and something that we have to keep in mind.
I just
Chelsea,
quickly, oh, go ahead.
You had mentioned earlier, Chelsea, about the, sorry, I forgot what I was going to say. Go ahead, please.
Okay, if it comes back, just say it. I
will.
think I'll just briefly, I'm glad you brought it up, Jason, because I was thinking about that as well. It's exceedingly rare, and we have to name that, because I think James's message around this, like, oh, there's, we get told that it's irreversible. I was told I was, never going to have a menstrual cycle again, and that never came to pass, that was true. So I think they're exceedingly rare, but I do think they exist. What we're really advocating for is that eating disorders and mental health conditions not be a qualifying condition for assisted suicide, which is, I think, a fairly basic thing. It's a very narrow argument, and there's much bigger conversations to be had as well around that. But I think the other thing to be named here is the role of palliative care, and I think so there's a role of palliative care, and then there's the question of, like, laws, in my understanding, are for the public, for everyone. And so we have to think about the consequences of a law when we pass one. So the laws that we have on the books now, which, in countries where it's not yet legalized, make it illegal to assist someone in suicide, are there for a reason. They're there to protect life, or to protect vulnerable people from being taken advantage of. And I worry about creating laws for single cases that might put public safety at risk. And that's how I think about that. As I go, of course, there are exceedingly rare cases that we can think of where maybe it would be appropriate. And I'm just saying maybe, if we grant that might be appropriate, do we create a law that might then put at risk many, many, many other people, not just people with eating disorders, but people with disabilities, people with mental illness, people who don't have access to housing? And that's what I worry about. And my sense is that we have palliative care is underutilized in those cases, that we need to have palliative care for those cases, because they do exist. They're very rare, but they do exist. And that our current laws are pretty well equipped to support those cases. I'm not sure why we're needing to change things for those. So that's my understanding. I don't know how others think about it.
I'll also interject a bit. I think there's also a conversation to be had about how people have this general distrust towards the medical system, especially if there has been harm in treatment. Like, I am someone who would consider myself a psychiatric abuse survivor. I experienced coercive mental health treatment. I was criminalized for suicidality. I have experienced cop involvement for suicidality and extensive trauma because of forced and coercive medical interventions that took place in the treatment of my eating disorder. And I think that the distrust that I have towards the medical system and treatment in general for eating disorders, and the ways that I've talked to psychiatric survivors who have similar stories to tell, and general distrust towards doctors, nurses, any kind of medical professional, is something that needs to be talked about, because how do we get those people to access care if they wanted to? How do they feel safe again within the medical system? But also, how can we keep people out of coercive medical treatments so that the harm is not perpetuated? Because I think that that can lead to this kind of terminal suffering that leads to people not wanting to get care.
See a couple questions in the chat. Is it okay if I go to those? Dr. Vig? Okay, all right, great. Wow, there's a lot here. It's a tough question. Oh my goodness. Okay. Let's go with, I'm going to go in order. Lorna asks, currently there are decisions about whether autonomy should be respected, often treatment refusals. So the question of whether treatment autonomy should be respected, meaning if a person wants to refuse treatment, should we respect that? It hinges on an assessment of mental capacity. It's widely recognized within the specialty that current assessments of capacity and eating disorders are very problematic. And I would add, they're not, we don't have validated sort of standardized measures of capacity and eating disorders. I would love to know what you think about this. Do you think it is a problem with how we conceptualize mental capacity? And what are your thoughts on this? Or is this something else? Talking about capacity to refuse treatment, and we're talking about, are clinicians very good at assessing capacity there? Anybody have thoughts on that?
For me, it feels very big, and I think that a lot of time, I just from my own experience, I think I've been told that I have capacity to make decisions about things when I probably don't agree, certainly in retrospect, and I'm sort of wondering why that is, but I don't necessarily have the solutions to that apart from maybe greater understanding of people may appear to be well and to perfectly understand what's going on for them. But I think, maybe more education around that would be helpful. But I do know the consequences of that as an individual, that it can be very stigmatizing, and that you end up feeling that, well, I've ended up feeling that I'm sort of somehow, on my head, be it if I have cardiac arrest or whatever. And I kind of wish that I'd been prevented in those situations. And I think that if you it kind of doesn't really make much sense to me that I was told that I had capacity, because it was capacity to do what, to say that I want to run the risk of dying. And I don't think that's psychologically very healthy. Like, I think that if somebody actively wants to be unwell, then that is probably a sign of something that needs treating, or a sign that they don't have the belief that it could be any different. And then that's the sort of whole futility thing as well. But that's probably all I can add to it. I just want to say there is one question in the chat that I really would want to come to, but I don't know if we should do it now or not.
I'm gonna just say something that I'll let you ask
Yeah.
the question in the chat. I'll thank you, James. I would add too that maybe one of the reasons your treatment provider thought you had capacity is because they may not have been very good at assessing capacity. Our mental capacity, it sounds very boring. It actually comes from the criminal justice system. We've brought it into the treatment system, and then we've tried to apply it across the board to everyone. And the studies that have been done, the very few ones that have been done, show that even eating disorder clinicians are not very good. They can't agree on which patients have capacity and which ones don't. The bar for mental capacity in even treatment decisions are very low. So I would just put a call out there for more education. I don't think most most eating disorder clinicians fully understand what capacity is, that it's not a characteristic of the person, but it's a decision specific measure. We need way more research on this, and we need way more training on this. And it's especially when it's being used to determine whether a person lives or dies. It's really consequential.
And can I just say too, though, I mean, predicting human behavior is very confusing. I mean, I've been a psychologist for 25, 30 years. If I'm assessing someone's capacity or if they're going to kill themselves, I mean, what's my percentages of knowing how I can predict that? So I just want to mention that I could get all the training in the world, which I probably have had quite a lot, but I've been in a court case where one side of the court is saying the person has capacity and the other side of the court is saying they don't have capacity. I mean, then you have to battle it out. And anyway, I think knowing capacity and predicting behavior are not, I mean, what if, oh, okay, what if I'm saying today I am suicidal, but then tomorrow I'm not? Or what if today I'm not, but then tomorrow I am, but you catch me the moment in time at midnight, but then it's 8 a.m. later? Anyway, I just want to say in defense of us, like, we don't know how to predict it. And it's hard to know that.
Yeah, that's great, Dr. Wig. Yeah, you speak to intermittent capacity, where a person may have capacity one day and not the next, especially if they have a mental illness. So that's beautifully said. James, yes, please give us a question. What's the question?
Yeah, it was just one that that really struck me that I can't really answer it, I guess, but it asks the question of us all, I guess. It's from Louise in the chat around that agreeing that recovery is possible, but what if the resources and treatment aren't there to meet your needs to help you to get to that point, and how much suffering is okay? And I think this is, for me, maybe this is sort of the big unanswered question, or the real question that's not necessarily being asked, is that I think I'm one to say, look, change is possible anytime and people can recover, and, et cetera, with the right conditions, the support, the treatment. If treatment's not working, maybe it's not intense enough, maybe people need more treatment, not less treatment. Like, I'm saying all of these things all of the time, but that's it. That's, I think, reality. That's what I understand is the reality of it. But the other reality that coexists is that the treatment and the support isn't there, for the vast majority of people. So whilst in theory it is a possibility that change can happen and people can live these amazing, wonderful, different lives and everything, if without this access to the support being there, then the people who are stuck in that position, well, how much suffering should they have to go through, and how much longer can they wait? And many people are dying, and these are preventable deaths, and in my view, and I think that this is the really sticky bit that we don't have enough answers for, is that, like, well, what are we going to do for these people? They've spent probably, half a lifetime waiting. How much longer could they be expected to wait? Who could blame them? Nobody, I don't think, for thinking that, I can't hold out for things to be different. And maybe they've had some experience of treatment and it's been harmful. So the next, if they are offered some from these shiny new services that we hopefully have in the future, will it address iatrogenic harm and trauma? Or will it just put them through something that might not accommodate that and might then be harmful again? So I think, like, what are we doing with this group of people? I think the answer is that we need the system change and the support and the resources, and different ways of doing treatment and different treatment models and all kinds of things, like now, or we need them like years ago. And I guess, how can everybody put as much effort into that as possible and answering that before putting the energies into, well, which ones of these people can we say are beyond the pale, and we're gonna sort of write off recovery completely for these people. So I think that is the really sticky bit, where there aren't immediate answers for these people. Like, I'm doing work to design and develop services. It's not enough. It's not happening fast enough. It's really frustrating. Some things have got better in the time that I've been doing the work that I've done, but none of it's benefited me. Hopefully it's benefiting me in the future. And I think I don't have any sort of neat answer for that, but I wouldn't blame anybody for feeling really hopeless about that. And we need to really hurry up.
I think, James, you have given us a perfect point to end on. And I'll just say kind of to that, it's one of the reasons that we have created this campaign around this whole study and event. You know, the study, I have to say, every time it looks really grim. I go to work and people kind of run away from me now because they don't want to hear me talk about this study. No, I'm just kidding. But it sounds really grim, but the actual message of the campaign is treatable, not terminal. So we want this very sad, tragic news to be a catalyst for a movement in our field. And I can't tell you how much I am holding hope. I'm so grateful to ANAD for standing with us on this. They were the first organization to come on board, and they remain really, in the eating disorder world, the sole big player up here on this joint statement. But I hold and remain hope that the other eating disorder organizations will come together with us on this, and that this is a movement and a push in our field for greater access to care, because we've had deaths. We are seeing deaths, and we are seeing the dangers of this. I also just share that we're doing, you know, everybody there. I know that, you know, it's not enough, but there's a lot of people offering a little bit. We offer a free course every single month. It is not a substitute for treatment, but it's peer support and yoga therapy and a place you can come and be with other people and, you know, just sit and listen if you want. But it is a resource. We offer a referral service for anyone in the world. We will find you and connect you with a treatment provider. ANAD also offers amazing free services. Will you tell us, please, Jason, about all the great things you guys do?
Yeah, so all of our services are free and accessible to anybody that's in need. So we've got our peer support groups. I think we're up to 18 of those now that meet every single week. We've got our peer support helpline, and we've also got our peer mentorship program. And we hear from people all the time who are facing those barriers and can't get to the treatment that they need. And while we're not a replacement for treatment either, we are that support, and we are that community that can at least help people in some way when they can feel so isolated and so alone with this condition. So Anna is always here to support anybody who needs it.
Thank you. So on that note, I think we'll close. I acknowledge, you know, just say, I know that's a small drop of water in a big pail of need. We need so much more than that. We need new treatments. We need funding investment. And it's why, you know, people, our whole kind of community are coming together. We're writing op-eds. I was on a call with a journalist before this. I'm writing to members of parliament saying, there have been deaths and we need treatment now. We need access to care now. So if this conversation has inspired you, please put your support down. Every single name on that joint statement means something. So you can join as a community supporter. If you're affiliated with an organization or you're a professional, please join us as a signatory. And we have another great event that James, I enjoy talking to James so much that I have asked James to be on another panel with, actually, I think she's here. Dr. Agnes Ayton will be with us on that panel, as well as Dr. Ali Ibrahim, Dr. Anita Federici, and Lorna Collins. And that's on creating access to treatment and advancing effective treatment for people with severe and long-standing or chronic, or people that have had their illness for a long time and are struggling to get treatment. So that's our next event. So much for being here. We'll have a recording sent out to everyone. Thank you, James. Thank you, Dr. Rago. Thank you, Jason. Thank you, Joss.
Thanks, everyone.
Thank you so much.